For me? No, I don't. It's on the printer. Be on the top. It should be on the top of the print. It's okay.
Good morning, everyone, and welcome to the 8th webinar of 2023, supported by the ACCP Immunology and Transplantation Parent. My name is Staci Serluco. I'm a solid organ transplant pharmacist specialist and the PGY2 residency program director at Children's Healthcare of Atlanta, and it is my pleasure to moderate today. Today's webinar is our annual ISHLT recap webinar. We're honored to have Ed Horn from the University of Pittsburgh, Stephanie Witek from the Hospital of the University of Pennsylvania, and Dr. Ian Hollis from University of North Carolina, Chapel Hill serve as our speakers today. In a moment, I will turn it over to Dr. Ed Horn to begin the presentation, but first, here are a few quick notes. For our audience members, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen. If at any point during the presentation you have a question for the speaker, please submit your question using the chat functionality at the bottom of your screen. Please send your questions directly to the moderator of today's webinar to minimize any possible interruptions. We will take questions at the completion of today's presentation. Today's webinar will be posted on the ACCP IMTR YouTube channel. If you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make the moderator aware through chat functionality. Now, without further ado, I will turn it over to Dr. Ed Horn.
Thanks, Staci, for that introduction. Just going to apologize in advance. I picked up a cold in the last 24 hours, so if my voice sounds a little raspy, I apologize for that. So we'll get into this. So this is my Rocky Mountain recap of the ISHLT in 2023. Like Staci said, I'm at the University of Pittsburgh. I'm an associate professor there at the School of Pharmacy, and I'm also the clinical pharmacist for the Heart Transplant and MCS service here at the UPMC Heart and Vascular Institute. I have no disclosures related to the content of this presentation. And one of the more striking things I thought that we saw at the presentation was this giant, or the conference, this giant bear that was outside of the conference center. And this wasn't the only big deal I thought that happened at the meeting. There were a lot of great talks that were given, and we're all going to highlight some different things that we saw that kind of piqued our interest. Something that was I thought that was interesting just to bring out as a overview of the entire meeting was the ISHLT added a bunch of new symposia formats for this meeting to really try and make it more interactive with folks that were attending. So we had the Pecha Kucha, which is Japanese for chit chat, where presenters would have 8 minutes to present a focused topic during that symposium. There were a variety of debates that were really great, and both of the debates in the Pecha Kucha, you actually voted for a winner if you were in the audience attending, which was pretty neat. We also had a game show format, and there was a traditional platform, so presentations of abstracts, so oral presentations, mini oral presentations, and so forth. There were 2 days where there were plenary sessions on Wednesday and Thursday. Wednesday had a review of the maribavir data for CMV and solid organ transplant, as well as a discussion really of some of the forced organ procurement occurring in China right now. On Thursday, there was a focused review, a focus really on health equity, both in the UK and the US, and and really focused in like lung disease. And that was presented by Elena Stanford, which was a really kind of interesting topic, and how she kind of talked about how she's built this, this whole network of outreach to get out into the community and help take care of patients with lung disease, which I thought was just really kind of fascinating. There was a variety of networking sessions. For those that were in attendance there, probably saw us at the pharmacy professional community networking session as well. And then we have the interdisciplinary network. So just for those who aren't familiar, the way the organization is broken out is that there's 4 IDNs, so the interdisciplinary networks. We have heart transplant, lung transplant, MCS, and pulmonary vascular diseases. And within those networks, we have our professional community. So it's kind of identifies you, what you do and how do you do it. So the what you do is your IDN, your interdisciplinary network, and the professional community is how you do it. So what's your profession? So there's pharmacist representation through all the IDNs, which really makes, I think, the organization unique and focused on multidisciplinary, a multidisciplinary approach to the science behind these patients. All right, so enough about that. Into my review. So I am going to step out of my comfort zone. For those that know me, know that I am absolutely petrified of lung transplant. I like to stay within the heart, and that's I'm really comfortable there. But there were a lot of sessions that were directed against, the sessions talking about medicines directed against antibodies with a focus on novel therapeutics in thoracic transplant and some like treatment conundrums. So I thought on Wednesday the 19th, we had Back to the Future of AMR, which discussed AMR and lung transplantation, and really outlined there's a multidisciplinary discussion outlining the challenges within lung AMR, really from when to treat. So when the diagnosis is probable, what do you do there? And what to treat with. There's new guidelines being developed in 2023 through a working group that to focus on the original criteria that was done years ago, as well as addition to biomarkers and discussing CLAD. And I say that all like I know what I'm talking about, but it's a little, again, out of my comfort zone for sure. But one of the talks in that session that was really neat was one done by Adam Cochran in Virginia, where he looked at, he talked about like buckets of medicines that we use to treat patients with, right? So he, through the traditional medicines that we have, rituximab and proteasome inhibitors, and like the leaky bucket, and so much as that there are holes in how they work, right? So we know that like proteasome inhibitors might not be great for class 2 as an example, for class 2 antibodies. There was the potentially leaky maybe slash bucket of daratumumab and tocilizumab as medicines that just don't have a lot of data behind them yet, but are exciting because they're new and they work a different way. And if you have a bucket full of money, then you can use eculizumab. So he kind of broke things out as like based upon the data and cost and all that stuff, which I thought was really neat. There was a big discussion in talking about interpreting antibodies and MFI, where Adriana Zeeby from here talked about the prozone effect and looking at when you look at antibody MFIs, and if you have a lower one on your knee and it gets higher as you dilute down, that maybe there's a prozone effect there that's happening. It's masking kind of what's going on, and really talk about the utilization of dilutions of a 1 to 4, 1 to 16 dilution to help determine the lower titer and complement binding antibodies. Which again is something that we've done here at Pitt for a little bit now. And again, I went over what the treatment options were for within AMR, and Adam really talked about really the fundamental finish on his talk was that we just need more buckets, and we don't fit, these therapies don't fit into one big bucket. That's what works great for each patient. Also on Wednesday, there was a really neat talk symposium on the diagnosis of heart transplant rejection, out with the old, in with the new, which really was a review of a variety of different technologies and rejection detection. So really not focused on biopsy per se, but focusing on non-invasive methods in some ways to talk about how these can help with detecting rejection in heart patients. There was a review looking at machine learning, and it demonstrated 91% accuracy, which is about as good as human. Which I may, I'm old, so the whole computer AI thing kind of scares me a little bit. But I think that that's kind of an interesting process here, where if the use of AI and computer-assisted biopsy reads. Discussion about microRNA and the GRAPH trial that's being used to establish a score cutoff for rejection. And what was seen there is that a score of greater than 65 showed an excellent receiver operator curves for rejection diagnosis. And then the use of MMDX, or the molecular microscope. Again, there's been a real, I think, a rapid expansion of both the adult and pediatric centers. I think it'll be interesting to hear from those in attendance how many folks actually have access to MMDX. I know we use it in our pediatric population to some extent. We haven't really expanded that to our adult population here yet. And then there was, again, an update on some of the things we already know about with GEP and gene expression profiling, or ALMAP, and cell-free DNA as well. Thursday, was a talk that I thought was really neat in talking about the immune checkpoint inhibitors in their use in thoracic transplantation. So this was a CHOA multidisciplinary discussion where a bunch of folks talked about, the use of ICIs in transplant recipients and some of the mechanisms behind how they work, and what to really watch out for. Mike Shulo did a nice presentation, and he won the CHOA that day. Whether he gets to defend his title in Prague, I'm not really sure how that's going to work, but I hope he shows up with like a championship belt or something like that. There was a real nice review on the use of them in transplantation. So kind of reviewing the data from 2022, a systematic review. Now, this wasn't just thoracic transplant, this is all comers, but we noted that the further out you were from transplant, the better response you're going to have with the immune checkpoint inhibitors. But there was a high rate of rejection and graft failure when these medicines were used in patients, in transplant patients. And if these were used in patients who are not on tacrolimus, the rejection rate was much higher, so 48.7%, 5.6, as you can see there. And the most common cause of death was either progressive malignancy or graft failure in this cohort. So I think for me, certainly took away from this as a class of medications I'm not super familiar with, but really made me think like, hey, if we're going to use these medicines in our transplant patients, we need to be on the lookout for rejection, because I think typically when we think about treating patients with malignancy, rejection is not really on the forefront of our minds there. So just something to I think keep in the back of our heads. Whoops. And then the next thing to go over, I think, was on Friday. I thought there was an interesting presentation called The Comedy of Errors. It was 4 presentations focused on primary graft dysfunction and heart transplantation. And for me, this is really interesting because we've rapidly expanded the use of DCD donors in our transplant patient population here, and we've certainly seen an increased risk, I think, of PGD in those patients. So I think it was nice to see presentations kind of looking at this and shining a spotlight on us as something where, hey, DCD is great and you can get hearts for your patients, but there's some cautionary tales there. So they looked at one paper looked at normothermic regional perfusion, or NRP, versus direct procurement, and was there a difference in those strategies? And there was a non-significant increase in PGD in the OCS group, which I think again we've seen here with some of our transmedics patients. And there was no difference in inotrope scores, 30-day survival and 1-year survival. So those first couple of days in the ICU after transplant tend to be rocky, but if it seems like we're able to pull patients through those things fairly well without a change in outcomes. And then there was also another paper that are looking at the impact of the UNOS policy change in 2018 on PGD after transplant. So how does that, and I think there's been a lot of hashing of data looking at pre-post 2018 in our patients to see what's kind of going on and how the field has changed drastically because of those listing criteria changes. And we know that there was a higher rate of right ventricular PGD after 2018, but again, survival 1 year does not seem to be different at this time. On Saturday, there was a survival and readmissions in HeartMate 3 talk that was done. And I think this is interesting, the HeartMate 3 versus transplant as primary treatment for advanced heart failure, right? So a patient comes in failure, and which path are we going to take for those patients? Is it transplant or VAD? And I'll think a lot of times people are like, again, the transplant has the best survival, but I'm wondering if that's going to start shifting at some point, So we know we can definitely see that 1 year survival is pretty comparable based upon these figures posted here. But long term, I think we still have the MCS patients still have some time to catch up. And there was also an increased note of readmissions for patients with the HeartMate 3 devices in these cohorts. So I think more to come there. And this again was looking at patients with strategy for primary management. So patients bridged to transplant off of LVAD were not included in this analysis. Another session I wanted to focus on too quickly in MCS was a mini oral session with the long-term outcomes. So some of it looking at the impact of non-cardiac surgery on long-term outcomes in our MCS patients. And what was noted here is that patients had a high degree of return to OR for bleeding. So about 7.5% of patients going through non-cardiac surgery had a return to OR, which I think is probably not surprising given the fact that we're anticoagulating these patients. It was kind of a hodgepodge of folks. So I think it'll be interesting to see how that looked depending upon the device, right? You know, HVAD and HeartMate 2, I'd imagine will be a little bit higher because you're going to be a little more worried about anticoagulating those patients. HeartMate 3, looking at the bridge transplant numbers before and again after that UNO status change, obviously more patients were transplanted off of HeartMate 3 before 2018. They had the listing advantage, which they don't enjoy now, as making it really hard for a bad patient to get to status 2. And then there was an interesting paper looking at the HeartMate 3 risk score validation. So linking the HeartMate 3 risk score to 1-year survival. And this is what the HeartMate 3 risk score takes into account as far as, you know, the variety of criteria that are posted there. And this was originally validated in 2022 with momentum eligible patients. This kind of took an updated real world approach to that. What they found is that, you know, this evaluated all patients, and it looked, there was an AUC of about 0.6 to predict one year mortality. So okay predictive model, but I think probably some work to still do there. And one last thing to go over, I'd be remiss if we didn't talk about some of the cardiogenic shock stuff. I think this is a really big area that ISHLT is trying to wade into the waters there, working with other organizations. So there was an MCS recovery oral session on Saturday looking, and it was interesting. I think, you know, they had Impella recovery, so single center in Italy, and had some factors of safe recovery, included prompt and complete revascularization, so getting to those vessels early, as well as an early upgrade to full support if needed. So maybe, you know, you come in on an Impella CP and you get put to a 5.5 real quick. And then long-term durable LVAD weaning was also discussed. I feel like for me, this is like the holy grail. Like we talk about this all the time in our patients, and I've seen it twice like in my life, and I really wonder if it's something we could get to more. There's analysis of the VAD wean registry, and that 1-year survival after LVAD removal was 83% in that cohort. So again, I think that would be it's something that's interesting to think about. And then using machine learning again to predict recovery using the UCAR score. And again, I think this kind of reflects real world, right? There was 528 patients they looked at, but about 15% had recovery. So I think again, showing that we talk about recovery all the time, but is this something that, you know, is probably fairly rare? And you can see what the UCAR score took into consideration here on the right in the cartoon. But it did predict reverse remodeling, which is neat. So just to wrap up, you know, again, the ISHLT is great, continues to provide cutting edge stuff in the field of heart lung transplantation, MCS. There's some new guidelines published for those. The wear and heart transplant was 2022 in the fall. MCS had guideline update in 2023, and again, we have to update the pulmonary AMR working group anticipated in 2023. And again, focusing on short and long-term MCS outcomes within cardiogenic shock recovery and long-term MCS survival continue to be the focus of the meeting. And I'll end it there and turn it over to Stephanie. Thanks so much for your attention.
All right, thank you. Let's see if I can manage to advance the slides. Awesome. So hi, everyone. As mentioned, my name is Stephanie Witek. I'm a transplant pharmacist on the other side of the state of Pennsylvania in the land of cheesesteaks at Penn Medicine in Philadelphia. This year is my first time attending ISHLT, so it was a great conference, learned a lot, and I'm excited to talk a little bit about some of the updates in lung transplant. Here's a list of some of the sessions that I'm going to be pulling some of the data from as expected for lung transplant. There's a lot of infectious disease topics, but some cool outcomes data to review as well. So starting off with talking about some of the newer agents available for CMV, Miranda So and Emily Blumberg talked about the pharmacological agents, letermovir and maribavir. So just going over some of the highlights and things to consider for these agents if you're going to be using them in your patients. So for letermovir, we know this was also just recently officially FDA approved for prophylaxis in the solid organ transplant patient population. Has a novel mechanism as a CMV DNA terminase complex inhibitor. So it is CMV specific, available both IV and PO. Major side effects listed were GI side effects, edema, fatigue, and headache. The great thing compared to some of our other antiviral agents is that there are no renal dose adjustments required for either of these agents. There are some drug interactions to be mindful of though. So letermovir is considered a minor CYP3A4 and substrate, as well as an OATP and PGP substrate. And so it may increase immunosuppression levels, and the guidance was to consider closer monitoring after initiation of letermovir. For maribavir, it is FDA approved for treatment of relapsed or refractory CMV. So it also has a unique mechanism. It's a competitive UL97 inhibitor. It's only available in an oral formulation, so something to keep in mind depending on what your lung transplant patient's access looks like. Major side effects were changes in taste, GI side effects, and fatigue. So notably, both of these agents have very different side effect profiles compared to some of the other available CMV agents. Maribavir also has some drug interactions to note. So it is a major CYP3A4 substrate, may also increase immunosuppression levels, but the main warning that was discussed is to not use along with valganciclovir because there is a concern based on its mechanism that it could result in decreased efficacy. Next, Heva Leister had a great talk in a session talking about management of fungal infections, where she focused on antimicrobial loss in the ECMO circuit. And so in general, we know that critically ill patients can have very altered pharmacokinetics compared to our average patient, and ECMO may further complicate that picture. It's been demonstrated ex vivo that lipophilic and highly protein-bound drugs may sequester in the ECMO circuit. You can have an increased volume distribution related to that sequestration, but also potentially due to hemodilution, depending on what priming fluid is used for the lines. If there's significant changes in blood flow to the renal and hepatic systems, there may be changes in clearance. And then if your patient's also on concurrent renal replacement therapy, you have an even more complicated picture. This comes into play with managing fungal infections because most of our antifungals are lipophilic and highly protein bound, and thus may be susceptible to sequestering in the circuit. This is a graphic that I pulled from the presenter's recent publication, which was a really nice overview of antifungal dosing in patients on ECMO. And there were three main factors that she suggested considering when you're trying to come up with an agent selection or dosing for an antifungal in your patient on ECMO. The first is, of course, related to the medications themselves. So what's the volume distribution? What's the % protein binding? How much would you expect that drug to potentially sequester? The second, and perhaps most important, is the patient factors. There's some evidence to suggest that critical illness itself may be the single most important factor when it comes to considering your antifungal dosing, and along with that, end organ function. And then lastly, considering your target organism. Is it expected to be a highly resistant organism, difficult to treat? One thing that she also talked about that I hadn't really thought of before was the impact of the materials in the ECMO circuit itself. So different tubing and different oxygenator materials may also have unmeasurable impacts on the rate of sequestering of the medication. So all of this is kind of summarized by this one line from her paper that I think is important to keep in the back of our minds when managing these patients, which is that the same drug may exhibit different levels of sequestration under different conditions. So day to day, week to week, your patient on ECMO may have variable pharmacokinetics. And this is a chart pulled from that paper as well, kind of trying to summarize the recommendations for how to dose and manage the medications. So focusing on the mold-active azole antifungals, so voriconazole, posaconazole, and isobuconazole, they are all relatively highly protein-bound and lipophilic, and we do have some evidence both for some ex vivo and also in vitro to suggest that they do sequester in the ECMO circuit. Important to note that a lot of the data for all of these drugs is not necessarily using non-ECMO control patients, so it can still be difficult to know how much is directly related to the ECMO circuit as opposed to critical illness itself. But given that we do have therapeutic drug monitoring available for these agents, the recommendation was to use it perhaps even more frequently in patients on ECMO than you would otherwise, so maybe once to twice a week for the duration that your patient is on ECMO and on these therapies. For the echinocandins, we see that they're also highly protein bound and lipophilic, but it's kind of a plus minus as far as the data suggesting how much is lost in the ECMO circuit. Some reports will say 50% of the loading dose is lost, others will say 85% was retained, so how clinically significant is it? Unfortunately, we don't have therapeutic drug monitoring available widely for these agents. And so in general, based on the limited data available, it's suggested that you don't need to make any empiric dosing changes other than how you would dose for your average critically ill patient. And then lastly, we have amphotericin B, which of course is complicated by the fact that there's different formulations, with the liposomal product being much more lipophilic and thus potentially more prone to sequestering the ECMO circuit. So that's why we get the plus minus depending on which formulation you choose, but also some conflicting data that suggests maybe not as much as thought is lost that we would think. So because of this, the guidance is kind of not well defined. You could consider using high doses of amphotericin B if you're concerned for therapeutic failure in your patient, or even considering switching them to the conventional product if they were on the liposomal product. Next, Faye Burrows, who's a pharmacist from Australia, did a nice talk in a multidisciplinary group for patients who may be nothing by mouth for prolonged periods of time after lung transplant and at risk of aspiration. So of course, she focused on pharmaceutical management in those patients. And she gave some great insight on some best practices for these patients. So of course, considering trying to avoid polypharmacy whenever possible. You know, does that patient really need to be on that statin right this instant? And this is certainly something we're thinking about for our patients across the spectrum of care, but especially important when we're looking at patients who may have very limited access. She was also making a good point to consider medication formulations and timing of administration. Are we coming up with a regimen that is feasible for a patient to do at home? Are we asking them to crush a bunch of pills every day? We want to try to make it as painless as possible. And then lastly, she suggested to consider the impact of thickening agents. Are we sure that whatever thickening agent that's recommended or the patient has is actually compatible with their liquid medications if they're able to take some things by mouth? Another part of our talk focused on some investigational agents that I'd never heard of before as pro-motility agents, if you're worried about aspiration, including some mechanisms I'd never heard of before. Unfortunately, when I was trying to look into them more, it seems that none of them are currently available commercially in the United States and are unlikely to be anytime soon, as it seems a lot of these got stalled at phase 2 trials, either because of a business decision by the manufacturer or perhaps just not proving as much efficacy as one would hope. So maybe more to come one day there. All right, shifting gears a little bit away from medications and more to general outcomes data, there was a great international discussion from physicians from multiple different countries about donor lung allocation. And so as we know, in the United States, we recently had the implementation of the new CAS system. And so they reviewed, how that compared to the prior LAS and the associated projections and how it'll impact outcomes and transplant rates and so on and so forth. But what I thought was especially interesting in this session was the comparison to some other country systems. So the French system was recently updated in 2020, and they shifted towards a geography and supply and demand based system. And the intent behind this change, as I understand it, was to improve equity across all regions of France. So you don't have one region of France where there's 5 offers per patient and another region where there's only 1 offer per patient. And their preliminary data analysis suggests that it's working. It's improving the rate of offers across the country, but organ discard rates, of course, are still a concern, and outcomes will still have to be further clarified after years of data because COVID did fall during this time frame. And then there's the Scandinavian system, which has been in place since 2009. So each country in the Scandinavian collection of countries does manage their own non-urgent patient allocation, but they do have the option to assign a highest priority to patients at an international level amongst those countries if they're listed as urgent. But what's interesting about that urgent status is they don't actually have defined formal criteria for who qualifies to be listed as urgent. They leave that up to each individual center, with each center getting the option to list up to 3 cases as urgent per year. So if you're like me, you're probably wondering what your committee meetings would look like if that was the case in the United States. And what was really interesting that they showed in their data is that it wasn't used as much as perhaps it could have been. So certainly some centers were using up all 3 of their urgent calls very early on in the year. Other centers were spacing it out more evenly throughout the year. And then there were some centers who weren't using all 3 at all. So there's further work to be done there to see, who would best benefit from being assigned to this urgent status. Are we just improving time to transplant, but are we also improving outcomes post-transplant? Some more to come there. So overall, this session concluded with the idea that allocation systems, of course, are going to continue to evolve and hopefully improve over time, but inequities do still exist. Moving on to patient-centered outcomes. This was a really interesting session, and this research was presented by one of the physicians at Cleveland Clinic, where they actually did a multi-center study seeking to correlate pulmonary function tests, specifically FEV1, to quality of life scores as measured by 2 different measures. As expected, the quality of life scores rapidly improved in the first months after transplant. These charts are kind of the opposite of each other. So the top chart, the lower your score, the better the quality of life is. And then the bottom graph, the higher the score, the better the quality of life is. So you can see that they kind of mirror each other and that there's improvement in those first few months. What was interesting is that the peak quality of life scores occurred more commonly after their peak FEV1 rather than simultaneously. And so the authors concluded that this suggests that there are factors that are other than lung function alone that may be significantly contributing to a patient's perceived quality of life post-lung transplant. And so elucidating what those factors are so we can direct a lot of our care there may be key to improving patient outcomes. All right, wrapping it up with some original research in the mini oral sessions, which were very rapid fire presentations of research. I wanted to focus on this one about multimodal pain control after lung transplant, because of course, pain control and opioid minimization is a big topic in all transplant. So this was a single center study. They included over 100 patients who received either systemic measures alone or along with liposomal bupivacaine or a cryoablation. Their primary outcomes were looking at average pain scores as well as median MME over the first 5 post-op days. And interestingly, median MME was similar across the groups. However, the average pain scores were significantly lower in the cryoablation group. And that's what that graph is depicting on the right. The black bars, which is the cryoablation group, you can see a significantly lower reported pain scores for each day compared to the other 2 groups. Interestingly, in spite of the same or relatively the same median MME, the incidence of ileus was also lower in the cryoablation group. And so the authors concluded that cryoablation reduced pain after lung transplant. The exact mechanism for this benefit and other potential benefits do require further investigation. And then lastly, rounding out with looking at some tolerability of immunosuppressant drugs in our patients with short telomere syndrome. Of course, there's unfortunately not much published in this space. So we have a relatively small retrospective matched cohort study where they did not find any significant difference in mycophenolate dose reductions, incidence of leukopenia, or overall major infection. However, a trend towards some of those outcomes being more common in the short telomere patients. So while this was relatively promising that maybe our short telomere patients aren't at increased risk for some of these outcomes, additional research is certainly needed to confirm that they're not at increased risk of infections. And that's all I have. I'll pass it on over to Ian.
All right, thank you. Make sure I can control the slides here. There we go. So my name's Ian Hollis. I'm a LVAD and heart transplant pharmacist at the University of North Carolina. I have no disclosures related to anything I'm going to talk about today. I'm going to go through a variety of different papers specific to MCS or LVAD. Some of these were, mini oral sessions. Some of them were posters. Some of them were abstracts. I tried to diversify a little bit. One interesting one I found looked at platelet function with the use of sildenafil during a durable LVAD. And so the background to this is that there are published papers, published experiences that show that using sildenafil after LVAD seems to have benefits that aren't readily explainable. So this could be things like less thrombotic events and reduced mortality. And so this group was starting to try to figure out the mechanistic reason why that might be true. So this was a single center study where they took stable patients with a HeartMate 3 LVAD, and they assessed platelet function by using activators. And I'll show you a slide in a second. And so they were looking at the amount of platelet activity that was stimulatable by these activators while patients were on and off sildenafil. So you can see they had about 43 patients, 16 of them were on sildenafil at a dose between 10 and 20 milligrams per day. And then they had a control arm. And what they found, I'll pull in some of the images, is that when they used collagen on the left or thromboxane on the right, the patients who were on sildenafil, their platelets were less responsive to that stimulation, indicating a little bit of an antiplatelet effect from the sildenafil. And so, you know, this could potentially be part of the reason why these patients have less downstream events. That being said, we don't really have data for other antiplatelet agents in VAD being all that important or protective, with the exception of maybe the hardware HVAD. And so I think there's a lot more to come on this. Interestingly, I found a commentary related to one of the papers. They're actually doing a prospective study where they're going to randomize patients to sildenafil or placebo with a HeartMate 3, and we'll start to see how robust that impact really is. But I thought that was pretty interesting. Next up, I really wanted to try to put something PEDS related into this presentation. It was hard to locate PEDS, LVAD related, medication related stuff. And so the best I could do was an analysis of the action network. And so for any of you who may care for PEDS patients with LVADs, there's basically a big network, sort of a consortium of institutions that do this work to try to learn from each other, get better, collaborate, share data, share protocols, perfect protocols, et cetera. So they did an analysis of this database over about a 4-year window. And they looked at, you know, the primary diagnosis, why the pediatric patient needed the MCS device, how sick they were, and then tried to correlate all that to eventual mortality. So they had about 850 patients. As you can see, they were about 5 to 6 years old, and a variety of devices. And I will admit, I am an adult advanced heart failure pharmacist. And so I don't absolutely know what all of these different types of devices mean. I know some of them, but it's a mix of permanent implantable continuous versus, you know, you may be external, you may be pulsatile. So different sort of technologies and modalities evenly distributed. Over a follow-up of about 3 months, the good news is about 2/3 of these patients do make it to transplant, which is often the goal. 10% of them recover to the point where the device can be removed. And unfortunately, about 10 to 15% do die. The mortality was correlated through a multivariate analysis to a handful of factors: biventricular heart failure, single ventricle disease, the presence of an external or paracorporeal device, and more severe intermax profiles. So things that are potentially predictive of a poor outcome. Interestingly, the authors were proud to show that this curve shows the mortality over time, and there seems to be an improvement, at least in the most recent data. And so this could be a result of better collaboration, better protocols, and just learning more about how to treat pediatric patients. And so with that, I'll transition to a study that I found really interesting. So this is durable LVAD, continuous flow LVAD, and looking at LV functional improvements. So Ed alluded to this earlier. We know that certain patients will have recovery of LV function. Sometimes it's intentional, sometimes it's not. Sometimes it just happens whether you do anything about it or not. Prior data and clinical experience has shown that when the LV recovers, it can create problems with the function of the durable LVAD, where the ventricle starts to compete with the LVAD for flow, and more blood may be going through the native circulation, less blood through the LVAD, and that lower flow could contribute to blood stasis, coagulability, et cetera. This study that I'm going to show you was an intermax analysis of about 10,000 patients, where they stratified them by what their maximal post-LVAD ejection fraction was. So they put them into buckets by how much they recovered after placement of the device. And then they looked at downstream thrombotic events, device thrombosis, strokes, hemolysis. And so what is interesting, sorry, it's taken a while to come up, in looking at how these patients fell into these different categories. So this table shows, first off, we have the overall sample size and how many patients ended up at each level of recovery. And so you can see that probably half of the patients didn't recover at all, and then you have progressively less recovery to the higher ejection fractions. What I thought was interesting is some of these pre-procedural characteristics that are somewhat predictive. And so if you look at the female proportion, it's 21% of the overall population, but progressively becomes a larger proportion of the greater improvement in ejection fraction. So potentially there's something about female physiology that is more amenable to recovery after LVAD. This is exploratory. I don't know if this is true for sure, but it came out of this data. Also, if you look at the presence of balloon pump and then a larger left ventricular end diastolic dimension and higher wedge pressure, which are all indicative of a sicker patient at the time of LVAD, basically the sicker you were by those parameters, the less likely you were to have a recovery in ejection fraction, which is sort of interesting as well. But then I think the real point of this paper was, how did it translate to thrombotic events? And so when they compared patients in the greater than 50%, 40 to 49, and 30 to 39% categories, they actually had less device thrombosis compared to the patients who had no recovery at all. And you can see the hazard ratios there. Patients in the 20 to 29% group was similar to less than 20. And so if you slice it by EF greater than or equal to 40% after LVAD, your hazard ratio of a thrombotic event goes down by about 28% if you had recovery to the higher ejection fraction. Strokes were comparable across across EF categories. And the risk of developing hemolysis was also lower the more you improved your ejection fraction. So I found this really interesting because it sort of contradicts earlier experience in that, we need to be worried if the patient's LV is recovering, that we need to do something about it, like device explant, to protect them from thrombotic events. That actually may not be true. Next up, we have really a process paper. And I found this one really interesting because we've tried to do some of this at my institution. And I will say, having seen this presentation, we are not doing it nearly as well as they are at UCSF. But the point of this was to basically say, like, the process of getting a patient ready for LVAD, putting them through the OR, the immediate post-op ICU care, the floor-based care prior to discharge, all that can be really kind of protocolized and plugged in an intentional manner to improve outcomes. And so you can see this protocol is based on sort of 4 principles. So they had a multidisciplinary planning meeting, and then they had clinical pathways for ICU and floor-based care, and then talking about how they were going to hand off to the outpatient setting. And so because I wanted you all to have the feel of actually being at the meeting, I actually took photos of these slides while I was there because I was so fascinated by it. So, you can imagine you're kind of down in front on the right side of the presentation room, checking out the slides. And so, basically they kind of took everything they wanted to happen and that they wanted to be intentionally done a certain way, and they mapped it out. And so you can see they have preoperative planning in terms of surgical planning, kidney protection, how they're going to manage RV protection. Then you have post-op stuff, which I'll show you, and then discharge. I realize it is very hard to see the data in these tables, but basically what I thought was cool is they had a sort of a mandatory meeting between the surgeon, the heart failure cardiologist, the anesthesiologist, and potentially some other folks within 24 hours of the LVAD placement to sit and talk through, okay, exactly what we're going to do and to get coordinated. And this document talks a lot about, the current state of the patient in the ICU, what meds are they on, what comorbid factors do they have, what types of procedure are we going to need to do. So just making sure everybody was on the same page. The next slide is about the pathway of care. And in the lower right, I realize it's a little tough to see, but they have a day-by-day grid. So they have post-op day, 1, 2, 3, out to about 7, and they have categories of care. And so they have immediate hemodynamic goals. So, what kind of cardiac index are we targeting? What CVPs are we targeting? The second row, which I realize is tough to see, talks about specific inotrope management. So this institution favors dobutamine and epinephrine as their primary inotrope combo. And then they have CVP goals that, sort of come down over time. So the CVP starts around 14, then goes to 12, then goes to 10 day over day. And they have plans for, aggressiveness of diuresis and that kind of thing. And then also anticoagulation. They have a day-by-day plan for escalation of IV and then oral anticoagulation. As the patient gets close to discharge and they're on the floor, we have a checklist. Have they been educated? Have family members been educated? The pharmacy portion of this process is a lot around meds to beds, making sure the patients have been educated. We use a med action plan at my institution, making sure all that gets done. Okay, so who cares? Well, the reason is when you look at their outcomes, you can see that their survival to hospitalization, that's the upper left, actually got quite a bit better. Their 1-year survival got a lot better. And in the bottom center, the 30-day readmission rates actually for a period of time were down to 0 with this plan. So I thought this was super cool because I think, it gets to just having a team-based strategy, making sure everybody's on the same page, making sure who's going to do what, and holding people accountable can really improve your outcomes. And then lastly, I just couldn't pass on this one. I was scrolling through the posters, trying to find something interesting, and this one jumped off the page. This is basically letting patients manage their own warfarin after LVAD. And so the background here is apparently during COVID at these centers, perhaps intentionally, perhaps not, some patients were managing their own INRs at home using home INR monitors and a protocol. So apparently this protocol was established in Australia. And so they shared this with a group in Europe, I guess. Let me see. Yeah, there's a European arm to this, Swiss arm. And so basically they picked patients and they trained them on how to manage their warfarin. I was not able to see the actual training. I think that would be fascinating. But then they were sort of cleared to manage their own warfarin, and they compared the time in therapeutic range and the cost of care before and after letting patients go on their own. And so they had 11 patients in the self-management program, 10 of them are HeartMate 3, and they followed them for about 7 months. Now, they had about 13 INR checks per month in the self-managed patients, which is roughly twice as many as the ones being managed by the providers. And so that may contribute to, the improved time in therapeutic range. They only had 1 bleeding event. Somebody showed up to a colonoscopy with an INR 2.8. That resulted in a bleeding event. I'm sure that also resulted in a lot of hand wringing and finger pointing. But that was the only one. There was no pump thrombosis. The time in therapeutic range in the self-management group was 90%, which is pretty impressive. And then they did a cost analysis where they kind of rolled all the things together, like what's the cost of a home INR monitor and the strips versus the cost of billing a patient for a provider's care time and all of that. And they found that letting the patients do it themselves was a lot cheaper. And so certainly not sure this is ready for widespread adoption across LVAD patients, but I did find it interesting. Like there probably are, if we all think about our programs, there's probably a couple of patients who, if you gave them the protocol that, like our coordinators often use for adjusting warfarin, they might be able to do it themselves. So perhaps more on this in the future. And so with that, I will stop. This concludes the 3 presentations, and we've got a few minutes left for some questions.
Thank you, everybody, for sharing all of these wonderful studies that were presented at ISHLT. I just have a general question for the group, so everybody is welcome to reply. So SGLT2 inhibitors have been a hot topic, especially among heart failure patients and possibly their use post-transplant in patients with left ventricular assist devices. So can any of you comment on any of the studies that were, whether it was presentations or posters that were presented on the use of SGLT inhibitors in different patient populations?
You know, I'll jump in. I can't say that I saw any specific LVAD related data on this at the meeting. It's possible I overlooked something. Just to further the conversation, I will say that we're using them pretty routinely post LVAD. We actually use them routinely in our ICU pre advanced therapies, often right up to the day of the surgery, for some of the benefits that can be seen there. I know there's a lot of planned work coming in this arena. I think some people are going to be looking at how they impact renal function after LVAD in particular. We use them occasionally after heart transplant. And I know that is where it perhaps is more interesting because, you know, you have the immunosuppression and the risk of infection. It's not our primary agent, but we have used a few of them with intermittent success. I think a few of them have been stopped due to, you know, a UTI here and there, but I'll sort of stop there and let Ed and Stephanie comment.
Yeah, I'm struggling to think of any posters or anything related to SGLT2s and especially lung transplant, but can also share anecdotally that our institution actually has a protocol to hold them before any anesthesia due to this risk of euglycemic DKA. And so for that reason, we do have to be cautious depending on how far out from transplant they are, how likely they're going to be coming in for a bronchoscopy and how much of a pain it would be to hold it. But otherwise, similar. We use it when we can, as long as there's not a huge infectious concern.
Yeah, sorry, I would echo those sentiments as well. We will use them, you know, a fair amount in our VAD patients, especially for folks that if we combine them with an MRA, you know, if they just need like a sort of a general diuresis where they don't necessarily need a loop diuretic every day or something like that. Like we find that to be a pretty good advantage there of the SGLT2s. But yeah, I didn't see anything specific per se. Now actually, while we were talking, I was trying to troll through the guidelines, the 2022 transplant guidelines. I'm pretty sure there's something in there about SGLT2s, but if, while we answer other questions, I'll see if I can dig it up while we're talking.
It looks like we have some time for maybe 2 or 3 questions. So if anybody in the audience has any questions, feel free to submit them in the chat.
I have a question for the crowd. If you had Ed Horn as an LVAD patient, would you let him manage his own warfarin? No. Ed, would you let you manage your own warfarin?
Maybe my wife as a anticoagulation pharmacist.
Looks like we have one in the chat. I'm not able to see the chat very well, so I don't know if someone can read that.
I can read it. So this question is from Hannah. She is asking, was there any data presented regarding photopheresis for rejection? Great question.
Oh, dang, there was. It's in like, it was like a special session that they did on photo. Steph, did you see that? I didn't go to it.
Yeah, I didn't either. I'm pretty sure there was, and I apologize that we can't include it. There were a lot of competing sessions. I forget when it was, but they don't have the slides online this year, as we all learned after the fact, but they do have some of the abstracts online. So you may be able to find some of what was referenced there.
There is a grant actually that was, I think, put forward by Mallinckrodt. Specifically looking at evaluating photo in transplant patients. So there may be more to come in future meetings with respect to that, Hannah.
I will say one interesting presentation I went to that I didn't include involved allowing LVAD patients to travel to other countries. And this one group kind of cataloged, I think they had about 20 patients travel to other countries. A lot of the countries did not have a VAD center in the country at all. And so they presented a table with like basically how it turned out. And so generally it went very well. They had like pretty much no complications. One patient came back, needed a little diuresis, no required hospitalizations. But the best part was during the presentation, it sounded like the resident who was presenting, like not all the travel was necessarily approved by the institution. It was just like patients just were kind of like, well, I'm going here. And, you know, and then somebody in the crowd said, well, what were you going to do? What was the plan if something went wrong while they were in these other countries? And they were like, yeah, we didn't have one. So anyways, I thought it was pretty entertaining because it was like, yeah, I mean, you can take your chances, but you know, it might get interesting if something goes wrong.
So we often joke about how easy the HeartMate 3 device is in our center. You know, it's so yeah, maybe them just going off willy-nilly managing their own Coumadin, and they got it
in another country. Yeah,
exactly. It's fine.
Yeah, no big deal. All right. Well, should we wrap up?
Yeah, it does not look like we have any other questions in the chat. So, and it's noon, so I guess we can go ahead and wrap up. Thank you everyone for the wonderful talk. And have a great Wednesday.
Thanks, guys.
Thanks for having us.